Guys, welcome to Medifaction. Today, let's learn about cataract. So, cataract refers to development of an opacity in the lens or its capsule. Cataract thus may occur either due to formation of opaque lens fibers or due to degenerative process leading to opacification of the normally formed transparent lens. So this right here is a normal eye, and this is how an eye with cataract looks like. Now let's see the clinical types of cataracts. First of all, we have the congenital capsular cataracts. It is again divided into anterior and posterior capsular cataracts. The anterior capsular cataracts are non-axial, stationary, and visually insignificant, whereas the posterior capsular cataracts are rare and can be associated with persistent hyaloid artery remnants. Next we have the polar cataracts. The polar cataracts are also divided into various types. First, let's see the anterior polar cataracts. These involves the central part of the anterior capsule and the adjoining superficial most cortex. It may arise due to delayed development of anterior chamber. In this case, the opacity is congenital, usually bilateral, stationary, and visually insignificant. So this right here is the anterior polar cataract. So these are thickened white plaque in the center of the anterior capsule. Next is the anterior pyramidal cataract. In this, the thickened capsular opacity is conical in shape with its apex towards the cornea. The next type is reduplicated cataract, otherwise called as double cataract. So sometimes, along with thickening of the central point of anterior capsule, the lens fibers lying immediately beneath it also become opaque and are subsequently separated from the capsule by laying of transparent fibers in between. The buried opacity is called imprint, and two together constitute the reduplicated cataract. Next is the posterior polar cataract. It is very common lens anomaly and consists of a small circular subscribed opacity involving the posterior pole. The posterior polar cataract is of two forms. The first one is the stationary form, and the next is progressive form, which progress after birth, and it typically has an onion whirl appearance, which you can appreciate right here, the onion whirl like appearance. So this right here is the posterior polar cataract. Next we have the congenital nuclear cataracts. In that we have the cataracta centralis pulverulenta. The word pulverulenta means powdery appearance. So the cataracta centralis pulverulenta is an embryonic nuclear cataract. It occurs due to inhibition of the lens development at a very early stage and thus involves the embryonic nucleus. The condition is bilateral and is characterized by a small rounded opacity lying exactly in the center of the lens. The opacity has a powdery appearance, therefore called as pulverulenta, and usually does not affect the vision. So this right here is the nuclear cataract. Next we have the lamellar cataract. It refers to the developmental cataract in which the opacity occupies a discrete zone in the lens. Right here, you can appreciate it. It is the most common type of congenital cataract presenting with visual impairment. It may be either genetic or environmental in origin. The genetic pattern is usually of familial autosomal dominant variety. The environmental form is associated with vitamin D deficiency, hypocalcemia, sometimes maternal rubella infection contracted between 7th and 8th week of gestation may also cause lamellar cataract. Some of the characteristic features of lamellar cataract are typically this cataract occurs in a fetal nucleus surrounding the embryonic nucleus. It is usually bilateral and frequently causes severe visual defects. The main mass of the lens, internal and external to the zone of cataract, is clear, as you can see here, except for the small linear opacities like spokes of a wheel which may be seen towards the equator. Right here also you can appreciate the spokes of a wheel-like appearance. So occasionally rings or opacities are also seen. Next is sutural and axial cataracts. So the sutural cataracts are comparatively of common occurrence and consist of a series of punctate opacities scattered around the anterior and posterior Y sutures. Such cataracts are usually static, bilateral, and do not have much effects on the vision. The individual opacities vary in size and shape and have different pattern and thus are named accordingly as under. First of all, we have the floriform cataract. So here the opacities are arranged in the form of a petal, as you can see right here. Petal-like appearance. Next we have the coralliform cataract. So the coralliform cataract is also known as fusiform or spindle-shaped axial cataract and is characterized by an anterior-posterior spindle-shaped opacity with offshoots giving an appearance resembling of a coral, as you can see right here. Next we have spear-shaped cataract. So the spear-shaped cataract, these are actually lenticular opacities and are in the form of scattered heap of shining crystalline needles. Then we have anterior axial embryonic cataract. The anterior axial embryonic cataract occurs as fine dot near the anterior Y suture of fetal nucleus. At last we have the dendritic sutural cataract. The dendritic sutural cataract occurs as fine dots along with the dendritic sutures. Next we have the total nuclear cataract. So this involves the embryonic and fetal nucleus and sometimes infantile nucleus as well. It is characterized by a dense, chalky white central opacity, seriously impairing vision. The opacities are usually bilateral and non-progressive. Now let's move on to generalized cataracts. First of all, we have the coronary cataract. It is an extremely common form of developmental cataract occurring about puberty, thus involving deeper layer of the cortex. The opacities are often many hundreds in number and have a regular radial distribution in the periphery of lens encircling the central axis. Since the opacities are situated peripherally, as we can see here, the vision is unaffected, but sometimes the associated large punctate opacities may marginally reduce the vision. Next one is blue dot cataract. This is the most common type of congenital cataract. It usually forms in the first 2 decades of life. The characteristic punctate opacities are in the form of rounded bluish dots situated in the peripheral part of adolescent nucleus and deeper layer of the cortex. The opacities are usually stationary and do not affect the vision. Next is total congenital cataract. So it is a very common variety and may be unilateral or even bilateral. In many cases, there may be hereditary characters. Other important cause is maternal rubella. So rubella cataract. The maternal rubella infection acquired during the first trimester may cause rubella cataract. The rubella cataract, typically the child is born with pearly white nuclear cataract and it is a progressive type of cataract. Next we have congenital membranous cataract. Sometimes there may occur total or partial absorption of congenital cataract, leaving behind thin membranous cataract. Rarely, there is complete disappearance of the lens fibers and only a fine transparent lens capsule remains behind. Now let's see the management of congenital and developmental cataract. First of all, we have ocular examination, which should be carried out with special reference to density and morphology of cataract. So the density is indicated by quality of red reflex seen on the distant direct ophthalmoscopy before and after dilation of pupil. The cataract morphology may suggest the underlying cause. The assessment of visual junction is difficult in infants and small children. An idea may be made from the density and morphology of the cataract by oblique illumination examination and fundus examination. Also, special tests such as fixation reflex, forced choice, preferential looking test, visually evoked potential, optic kinetic nystagmus test, all these can be done and they may provide some useful information. Laboratory investigation should be carried out to detect following systemic associations in non-hereditary cataracts. Intrauterine infections, which is toxoplasmosis, rubella, cytomegalovirus, and herpes virus by torch test. Galactosemia by urine test for reducing substances, red blood cell transferase, and galactokinase levels. Lowe syndrome by urine chromatography of amino acids. Also, hyperglycemia by blood sugar level test and hypocalcemia by serum calcium and phosphate levels and also X-ray skull. Now let's move on to the acquired cataract. In that we have the age-related cataract. The age-related cataract, also called as senile cataract, is the commonest type of acquired cataract, affecting equally persons of either sex, usually above the age of 50 years. The condition is usually bilateral, but almost always one eye is affected earlier than the other. Etiology or cause. The senile cataract is essentially an aging process. Though its precise etiopathogenesis is not clear, the various factors implicated are as follows. So some of the risk factors are, as I told, first of all we have the age, the sex of the man, the heredity, ultraviolet radiation, dietary factors, dehydration crisis, and also smoking has also been reported to have some effect on the age of onset of senile cataract. In numerous studies worldwide, smoking has consistently been associated with an increase in the frequency of nuclear cataract. Now let's see some of the most common symptoms of cataract. First of all, we have glare. Then uniocular diplopia, that is doubling or tripling of objects, as you can see here. Next we have colored halos around the light, poor discrimination of color, black spots in front of eyes, also deterioration of vision. So these are some of the common symptoms of cataracts. Now let's see some of the other types of cataracts in which we have the metabolic cataracts. So these cataracts occur due to endocrine disorders and biochemical abnormalities. A few common varieties of metabolic cataracts are described here. First of all, we have the diabetic cataract. The classical diabetic cataract is also called snowflake cataract or snowstorm cataract. It is a rare condition usually occurring in young adults due to osmotic overhydration of the lens. The osmotic overhydration of the lens occurs due to accumulation of sorbitol when glucose is metabolized by NADPH plus dependent aldose reductase. Initially, a large number of vacuoles appear underneath the anterior and posterior capsules, which is soon followed by appearance of bilateral snowflake-like white opacities in the cortex. Such opacities may resolve spontaneously or mature within a few days. Next we have the drug-induced cataracts. In that we have the corticosteroid-induced cataract. The posterior subcapsular opacities are associated with the use of topical as well as systemic steroids. Exact relationship between dose and duration of corticosteroid therapy with the development of cataract is still unclear. However, in general, prolonged use of steroids in high doses may result in cataract formation. Children are more susceptible than adults. Therefore, it is recommended that all patients with diseases requiring prolonged corticosteroid therapy should be regularly examined on slit lamp by an ophthalmologist. Further, intermittent regimes should be performed or preferred over regular therapy, and whenever possible, steroids should be substituted with NSAIDs, that is, non-steroidal anti-inflammatory drugs. Now let's see the management of cataract in adults. The treatment of cataract essentially consists of its surgical removal. However, certain non-surgical measures may be of help in peculiar circumstances till surgery is taken up. So some of the non-surgical measures are adequate control of diabetes mellitus when discovered, removal of cataractogenic drugs such as corticosteroids, phenothiazines, strong miotics may delay or prevent cataractogenesis. Early and adequate treatment of ocular diseases like uveitis may prevent occurrence of complicated cataract. Measures to delay progression include topical preparations containing iodide salts of calcium and potassium are being prescribed in abundance in early stages of cataract, especially in senile cataract. Role of vitamin E, aspirin in delaying the process of cataractogenesis is also mentioned. Surgical management. Indications. Visual improvement. This is by far most common indication when surgery should be advised. Visual improvement varies from person to person depending upon the individual visual needs. So, an individual should be operated for cataract when the visual handicap becomes a significant deterrent to the maintenance of his or her usual lifestyle and profession. Medical indications. Sometimes patients may be comfortable from the visual point but may be advised cataract surgery due to medical grounds such as in the presence of lens-induced glaucoma or phacoanaphylactic endophthalmitis. Hope you understood the video. Like, subscribe and press the bell button for more videos. Thank you. Thank you for listening.